talk is on aortic valve disease, and it's one of the commonest conditions that we treat. So I'm going to focus a lot on some of the basic anatomy, pathophysiology, and then we'll go on to some of the investigations and the management. This is where I'm normally based at St Thomas's Hospital. It's one of the great hospitals to work in the country. It has a very great tradition of education and teaching, and especially in the context of cardiovascular disease, many fine innovations have been emanated from here. The history goes back to the days of Lord Brock. In the early days, he was one of the pioneers of lung and heart surgery at Guy's Hospital, and a mentor for Donald Ross, who was a pioneer of the early valve procedures. The first ever biological procedure was actually the homograft, where he took the pulmonary autograft and put it in an aortic position, the Ross procedure. And subsequently, the innovations came in terms of the development of cardioplegia. The solution that's used all over the world, St Thomas's cardioplegia solution, was developed in our institution. These were the objectives I was tasked with, essentially, to go through. So we'll do it step by step, and hopefully allow some time for questions. Everything starts essentially with anatomy, and we know we've studied anatomy at all different remits, whether you study at GCSE or A-level or medical school. Really, when you become a surgeon, the surgical anatomy is really very key, because it's important to know the anatomy, the pathology, but also when we're doing any corrective procedures. In surgery, we're trying to restore anatomy, restore physiology. And the close relationship of all of the valves is really crucial. What we have, all the valves are actually very close to each other. We have here, and the aorta, or the tricuspid, the pulmonary artery is very closely related, but these three are so intricately related that any disease process of each of them can affect the other. This just shows you the actual skeleton, so the fibrous skeleton, which involves the anterior and posterior fibrous troglodynes here, the annulus of the aortic valve, and also the tricuspid valve annulus are all very closely related. Now, looking down at the valve, so when we from a surgeon's point of view, when we've opened the aorta, we look down, and what the aortic valve essentially consists of is 3 leaflets, and the leaflets are in close relation to the coronary artery. So the left coronary cusp, the right coronary cusp, and the non-coronary cusp. And these themselves, when we open up the aorta, what we can see is these leaflets have these subcommissural triangles. So they're these little triangles in between. And the annulus of the aortic valve, it looks like a nice circle here, whereas in fact, it's actually a crown-like structure. And this shows you from a surgeon's point of view, when we're doing an aortic valve, we've exposed what we can see is not only the valve leaflets, here the leaflets are excised, but we can see that the mitral valve is very close, and the mitral valve is essentially has the papillary muscles. The anterior leaflet of the mitral valve is almost continuous of the aortic valve annulus, and underneath the commissure of the right coronary and the left and the non-coronary is this area called the membranous septum. This actually has a different consistency to the rest of the annulus, and in this area what we find is the bundle of His, the right and the left bundle of His. This is a schematic. This is taken from a very good book, which I recommend, Surgical Anatomy of the Heart by Robert Anderson and Cook. And this shows you just nicely schematically where each of these major structures lie: the coronary ostia, the bundle of His, the papillary muscles. Now, the aortic root has many different components. It's not just the aortic valve. It consists of the sinuses, so the aortic valve leaflets, the sinuses, the sinotubular junction. Each of these have a very key role in the actual function of the aortic valve. The aortic valve leaflets open and close. Within the sinuses, that's where we develop the eddy currents that help in the valve closure. And the sinotubular junction is a very key in maintaining the competence of the aortic valve. One of the things we all know about is the Think Aorta campaign. This is particularly in the context of aortic dissection. We should remember chest pain, the cause of aorta as a cause of aortic dissection. When I walk across Westminster Bridge, as we can see here, to St Thomas's Hospital, sometimes when the sun shines on a particular time, it's often around about 2 o'clock in the afternoon, we get the projection of the aortic root, and the same as when you walk across towards Westminster. Aortic stenosis actually is one of the most commonest heart conditions, and calcific aortic disease is what we find in developed countries. In third world countries, it's more so rheumatic heart disease. And this was a cohort of studies from the National Heart and Lung Institute in the United States, and also Olmsted County cohort. These were patients randomly selected across the cohorts, and they looked at the age cohorts in these two different studies. And what they found is the older you get, the increasing incidence of moderate to severe aortic stenosis, to the extent that when you're almost over 75, almost 5% of the population have got moderate severe aortic stenosis. So there's a huge burgeoning population of disease, and there's an unmet need to treat this population. Many patients who end up diagnosed with this always ask, what is the cause? And there's been many, many studies looking at this, where it originates, what could be the cause. And it's essentially like many conditions, similar to atherosclerosis. There's a process of inflammation. The first stage is often lipid infiltration. You get endothelial damage of the leaflets, and that predisposes to some infiltration of the lipids. Then there's various inflammatory pathways involving various mediators such tumor necrosis factor, angiotensin 2. The end result is that you get this fibrocalcific deposition. So the leaflets start to get increasing deposition of calcium. And this is the spectrum that we see from normal leaflets to aortic sclerosis. Sclerosis is the thickening, the lipid infiltration, inflammation. Many patients have got aortic sclerosis, but not significant aortic stenosis. Aortic stenosis is a progressive condition. It goes from mild, moderate to severe, and we'll talk about how that's quantified. The very first descriptions of the condition of aortic stenosis actually came from Paul Wood. Paul Wood was a cardiologist at the Royal Brompton Hospital, the National Heart Hospital at the time. And in this lecture he gave in 1958, he described aortic stenosis as a simple mechanical fault, which, if severe enough, imposes a heavy burden on the left ventricle, and sooner or later it can overcome. And so this was the era even before open heart surgery had really taken off. Cardiopulmonary bypass came along in 1955, but the first operations to treat aortic stenosis were not until at least a decade or so later. But what he identified is essentially aortic stenosis as a mechanical cause, and thereby, by correcting that, you can restore the function of the heart and restore the patient's symptoms and quality of life. The causes, there are many causes. The most common nowadays is calcific degenerative, so calcification of the leaflets that happens of age. Some babies are born with subaortic membranes or severe aortic stenosis that need to be treated either by surgery or valvotomy. Rheumatic disease we still see in this country. Infective endocarditis causes more aortic regurgitation. There are other inflammatory conditions that can be associated, such as SLE, which causes nodules and thickening like rheumatoid disease. Irradiation is something that has been documented. It can not only cause porcine aorta, calcification of the aorta, but it can also affect the valves themselves. And then an iatrogenic cause of aortic stenosis is prosthetic valves. Many patients who undergo valve replacement, when we put a new valve in, we have to make sure that that valve has got a good enough orifice area so that it allows the patient's heart to function normally. But in some cases, if the prosthesis is too small, for instance, a very large patient, a very large BMI, then you can end up with this concept called patient prosthesis mismatch. Bicuspid aortic valve is actually very common. It's between 0.5 and 2% of the natural population have got bicuspid aortic valve. It presents in a much younger age, and there are different categories. You can have the pure bicuspid valve, where there are just two leaflets. You've got two leaflets, the anterior and the posterior, and this has two commissures. So that's called a type 0, a pure bicuspid valve. More commonly, what we get is the type 1, where we have a raphe, which is basically a little membrane that forms between the two leaflets, commonly the left and the right. So you can see the left coroneosity here, the right coroneosity. When this raphe forms, the leaflets thicken, they contract, and you can have aortic stenosis or regurgitation. Type 2 is rarer, where you've got two raphes here between, you've got the commissures here, but the leaflets are all fused. So bicuspid aortic valve is something which is important when we're taking a history from patients to find out if there's a family history, if someone has had previous aortic valve disease in their family, and could it be a bicuspid valve? Whenever I do any operations, or I take my trainees through it, what I try to do is take out the valve in situ. So you cut round the leaflets, so you take it all out. partly it's nice to get all the calcium out in one go. Secondarily, you can show the patients and you can show them what the valves look like. So this shows you different types. Here we can see a functionally bicuspid valve where these commissures are fused. This one you can see is a true bicuspid. There are just two leaflets there, and similarly to this one. And so you can see the different consistencies and what the valves can appear like. Now, the pathophysiology, when you're getting an obstruction, what we know is as the valve gets tighter, there's increased resistance to the flow. So the pressure that the ventricle has to generate has to increase. One of the principles of physics that we use in other contexts are the law of Laplace, which relates to the stress in the left ventricle, the pressure, and the thickness and the radius. So the left ventricle compensates by this increasing pressure by becoming thicker. What we get is a process of concentric left ventricular hypertrophy. And as the ventricle hypertrophies, that generates higher pressure to allow the heart to produce a cardiac output. This is what we can see here. So as we're getting the ventricle thicker, as we're getting a stenosis, the ventricle gets thicker, you get a ventricular hypertrophy. As the ventricle gets thicker, you can eventually get myocardial fibrosis. And what we know is as the ventricle gets thicker, the demands of the ventricle increase. So as you get more ventricle, you need more coronary supply. The coronaries supply the ventricle in diastole. So we get reduced coronary flow reserve. And this can manifest in symptoms. So if you get an imbalance between the demands of the heart and the coronary supply, that's one of the causes for angina. Another cause for the angina, the one you can get, is due to decreased flow into the coronary arteries themselves. So these are the pathological changes that you get: left ventricular hypertrophy, myocardial fibrosis. Eventually, when you get to a point where the ventricle can't cope anymore, then you can get left ventricular failure. Many patients who are found with aortic stenosis are just found by incidental murmur. They can be asymptomatic for a long time. They can be followed up with mild, moderate, or even severe aortic stenosis, can be completely asymptomatic. However, the deadly trilogy of symptoms are syncope. Many patients present suddenly with reduced flow to the cerebral circulation. They get angina on exertion due to reduced coronary flow due to the increasing demands of the ventricle, and they get dyspnea. And the dyspnea is due to the fact that you're getting increasing left ventricular and diastolic pressure. That in itself transmits on the left atrium, and then you get increasing black flow in the lungs. And there are the good small proportion of patients that just present with sudden cardiac death. And that's why patients who have got critical aortic stenosis and symptomatic, they are very urgently prioritized to have surgery. This is from the Netta, which is a very nice diagram. What it shows you is that the pathophysiological and symptomatic effects. So the aortic stenosis causes obstruction to flow. So you're getting coronary insufficiency. You're getting left ventricular distension, you're getting hypertrophy. What that can do is it can affect the backflow on the left atrium. So you're getting increased left atrial pressure, you're getting pulmonary congestion and dyspnea, and the reduced flow to the carotid circulation that can result in cerebral insufficiency, dizziness, and so forth. The classic sign that we find is an ejection systolic murmur. That's described often as a crescendo, decrescendo. So you get a raised increase in the pitch and then a decrease, a crescendo, decrescendo murmur, which is related to the flow of the blood as it goes through the tight aortic stenosis. The other features that you can get is a slow rising pulse. You can see that more pronounced in the carotid, a very slow carotid pulsation. One of the first articles on the natural history of aortic stenosis came from the Eugene Braunwald. There's a very good textbook, which when I was an SHO, I resorted to. It's called Heart Disease by Eugene Braunwald. And in this paper from 1968, he studied the natural history of patients who had aortic stenosis. In those days, again, this was before there was any given treatment. They looked at a whole series of patients, followed them up, and then looked at when they died, and using post-mortem analyses, they looked at the cause of death. And they found that there was a very long latent period of these patients who've been followed up for many, many years. They found that within years of symptom occurring, many of these patients would die. So the symptoms were particularly, they found that if you had heart failure, that was a late end stage symptom that showed already the ventricle wasn't coping, that was causing congestive cardiac failure. Syncope was a very alarming symptom, and angina. This was the sort of landmark study that was done way in the 60s. People have now looked at that since, and now we find many because we found patients living longer, the patients are presenting later. So you're having this long latent period. You have patients now presenting at a later stage, and when they get the symptoms, there is a similar drop off in their mortality. So having to intervene before the symptoms become too severe is the key. There's even a drive to operate now on asymptomatic patients. In terms of basic investigations, one of the key tests one would do is an ECG. On the ECG, what you'll see is some of the pathological features of aortic stenosis. You'll see left ventricular hypertrophy, which can be seen here in the lateral leads. You get a very high QRS complex. You also see sometimes some strain here. You get this ST depression. So left ventricular hypertrophy can be one of the screening mechanisms. And recently there was a paper that looked at about hundreds of thousands of patients with hypertrophy and use that as a marker using artificial intelligence to screen for aortic stenosis. And they found that using ECGs, you can use that very effective to screen patients for aortic stenosis. So that's another way that technology is being used now to screen patients and diagnose them at a much earlier stage. Having diagnosed the aortic stenosis clinically, what we need to do is quantify the severity of aortic stenosis. And this uses a bit of physics, a bit of calculations, which I'm going to take you through step by step. So it's quite important to relate what we see anatomically to the changes physiologically. So the best form of measuring this is a transthoracic echocardiogram. And the best view that we use is often this view, which is called the parasternal long axis view. What that allows us to do, the whole of the left ventricle, except the apex, we can see the left ventricle tract where the aortic valve is. We can see the sinuses, the left ventricle and the left atrium, the mitral valve. This view allows us to look at flow along this plane. The other view that we use is the parasternal short axis. So that slices the heart in a cross section, and we can assess the aortic valve. Here we see a tri-leaflet aortic valve looking at the 3 different leaflets, the right, the left, and the non. And we can look at the different views, and you can look at the degree of calcium and the degree of stenosis. And there's a lot of analogy with aortic stenosis and the common garden hose. So if you imagine you have a normal hose, you can increase the flow in the hose by at a maximum. You have a nice big stream of flow coming out. However, if you have a very small narrowing here, if you have a pin-like opening here, what that does, that increases the spread across this. So you have a difference. What we're doing is we're creating this jet velocity by narrowing the orifice area so that the aortic valve narrows here. And what we can do is we can measure the velocity before and afterwards. And this is one of the principles. It's where we measure the aortic valve area using these different parameters. So here we have a small little orifice here area, that's the aortic valve area, and we're measuring the velocity before and we're measuring the velocity afterwards. Using those, we can create a formula whereby we can calculate the aortic valve area. And similarly, this is another equation. It's called the continuity equation, which basically implies that it's one of the parallels of the Newton's physics, where you look at the continuity of energy, where it implies that the energy before the valve should equal the energy after the valve. We can the area of the valve and also the gradient across the valve. So to measure these, what we do is we use the ultrasound. We measure the area of the LVOT, the left ventricular outflow tract. And what that does, that allows you to then put a special beam of Doppler across that using the apex. So here, the apex of the ventricle, we can pass a beam of Doppler ultrasound across that through the valve. And then what we want to see is we want to see the flow of the blood across that. And when you've got aortic stenosis, what you find is you find this nice envelope here, which is a nice downward stroke. And that's actually the velocity. That's called the VTI. So the aortic valve velocity is measured using this particular echo. And that can be then related to the gradient. So having measured the velocity using this, we measure the velocity across the aortic valve, the VTI. The VTI gives us a very nice way of measuring the gradient. There's this formula here is called the Bernoulli equation. So the gradient between these two, the left ventricular outflow tract and the aortic valve, aortic aorta, is measured by this 4v squared. So 4 times the velocity of this equals the gradient. And that's now used to equate to the degree of stenosis. So any velocity more than 4 meters per second is what we deem as severe. Another way of measuring the severity of aortic valve is using a cardiac catheter. So previously, the way to measure was passing a wire through the aortic valve, measuring the gradient in the left ventricle. This will be the peak left ventricle, and then measuring measuring the peak inside the ventricular cavity. So this would be able to measure the difference. So the pressure in the aorta, the pressure in the ventricle would give you a gradient, pressure gradient, which could be used to quantify the aortic stenosis. Now, when it comes to severity, as I mentioned, the way we deem it is severe is by more than 4 meters per second. That relates to a mean gradient of more than 40. So these are the key numbers to measure: a transaortic Vmax more than 4 meters per second, and a mean gradient more than 4 meters per second. The aortic valve area, which is the actual area of the aortic valve itself, anything below 1 meter per second is deemed as severe. Anything more than less than 0.6 is critical. So these are the markers of severe aortic stenosis. This just shows you an echocardiogram. So here we can see a moving echocardiogram. This is the aortic valve. You can see the leaflets are moving a little bit there. There's a small gap in between. And here we can see on much closer, you can see the leaflets are thickened, the calcium. We can see some backflow of blood. There's a bit of mild aortic regurgitation. And then looking from the short axis, you can see here the lumps of calcium. The leaflets are opening, but not so much. And then when we measure that, according to this formula, we can see the aortic valve velocity is 4.9 meters per second. We've measured the velocity in this envelope here, and we measured the mean gradient as 41 meters, the peak gradient 73 meters, which essentially equates to severe aortic stenosis. Now, the guidelines for the management of aortic valve disease and all valve disease come in this and what of cardiologists, surgeons, a heart team, and they basically formulate the treatment for these conditions. One of the most significant developments in the last 20 years in cardiac surgery and the whole of medicine has been the evolution of TAVI. In the very early days, TAVI was used by high-risk patients, patients who were deemed too high risk, inoperable for surgery. And this was just shows you how these trials developed. The first trials looked at patients who were too sick, was superior to medical treatment. Next cohort was looking at patients who were in the higher risk surgical group, and they used different markers, the American SCTS score, to deem high risk for surgery, and they found that TAVI wasn't superior, it was non-inferior to surgical AVR. That then led to the next cohort, which was intermediate, partner 2A. And similarly, in this particular very controlled set of patients, they found it was non-inferior. And more lately, they found in low-risk patients, there's no difference. So now this has influenced the guidelines. Now we're finding that the guidelines are reflecting some of these trials. Previously, surgery was the standard treatment for aortic valve disease. It was a gold standard. And patients who couldn't have surgery for inoperable used to go for TAVI. Now things are changing such that patients who can't have TAVI may end up having surgery. What the guidelines say is anyone who has symptoms of aortic stenosis, they should be evaluated by a heart team. And now, rather than risk per se, age is being used as a sort of cutoff. So anyone who, for instance, is less than 75 and they're low risk, they'll go for surgery. Anyone who's over 75 or has some high risk features will go straight for TAVI. Other patients it may be assessed individually and may go for either option. So this is how we're seeing the change in the way patients that we treat overall. So the main drivers for intervention are symptoms and severity based on the valve gradients. Now, for asymptomatic patients, it's still quite controversial. There's some evidence suggesting that if patients are truly asymptomatic, you should maybe watch them, or you do some exercise testing. If you do an exercise test and you see a change in the exercise test, that might drive them towards surgery. However, there's there is some evidence now coming on board. There was a trial performed which was published in New England Journal of Medicine, which looked at 145 patients who were asymptomatic, and they randomized them to early surgery or conservative treatment. And they found that patients who actually had early surgery, they had a better outcome at 4 years in terms of less mortality. So now there's a move towards assessing patients and offering them early surgery at an earlier date. Let's move on to aortic regurgitation. It's less frequent, and it has a much more diverse range of causes. It can be caused, which are connective tissue disorders. A cuspid valve is one of the common. Hello.
Sorry to interrupt, Mr.
Sorry.
You're getting some interval network dropout, so sometimes your voice isn't coming through as clear.
Oh, sorry. Can you hear me now?
Yes.
Sorry. So aortic regurgitation is affected by many different conditions. Many of them are connective tissue disorders, such as the Marfan syndrome, which can cause dilatation of the aorta, dilatation of the roots, and weakening of the leaflets themselves. There are other conditions such as infective endocarditis. What that does, that can destroy the valve leaflets and you get vegetation, so blood pours through. There are degenerative conditions. Sometimes you can get calcification. Another cause of acute aortic regurgitation is aortic dissection. When you get a tear in the aortic root, that can sometimes disrupt the commissures and cause severe aortic regurgitation. When we classify this regurgitation, there are ways of classifying the mechanism. So we can have aortic regurgitation due to normal leaflet motion, but it can be due to the dilatation of the annulus. That's called functional aortic regurgitation. And then we have leaflet disease, so cusp perforation by cuspid valve rheumatic. For physiology regurgitation, because what we find is initially when you have aortic regurgitation, the blood will go back through the aortic valve, the left ventricle. In the acute situation, if the ventricle doesn't have time to adapt, you will get a reduction in the cardiac output because the ventricle has not had time to adapt, so you get a reduced cardiac output. The patient can go into cardiogenic shock. In many cases, it's often a chronic condition. So as the ventricle, as you get aortic regurgitation, the ventricle does adapt, the ventricle enlarges, you get some hypertrophy, you get some dilatation, and that's a compensatory mechanism that allows the ventricle to adapt. And that's one of the reasons why many of these patients remain asymptomatic for a long time until they start to develop symptoms. The symptoms are classically dyspnea, chest pain, and the chest pain can be due to reduced diastolic flow down the coronary arteries. We know during diastole is when the heart receives coronary flow. So decreased diastolic pressure as the ventricle enlarges, that can affect the coronary flow. There are many eponymous signs. We know you can get the water hammer pulse, the collapsing pulse can be done when you lift the arm up. You find that they're very strong pulsation. There are things such as the de Musset sign, the systolic head bobbing. There can be things such as the pistol shot femorals, and then also things such as the Quincke sign, the capillary pulsation. When I was doing the research for this talk, I discovered another sign, which is called the Ashrafian sign, and this is pulsatile pseudoproptosis. And this was actually, I found this, Hutan Ashrafian was my SHO many years ago in 2005. He was an SHO at St. Mary's Hospital. A patient came in with very severe breathlessness. They found aortic regurgitation, and he found that they had pulsatile pseudoproptosis. The eyes were sticking out almost as if they had thyroid disease. When they looked at the thyroid function, it was normal, but they found that the pulsation of the eye was actually related to the aortic regurgitation, and you described this phenomenon. The murmur that we get is often early diastolic murmur, and that's often better when you sit the patient up in the forward position. Now, quantification is very key, just like aortic stenosis, and the way that we do this is by measuring the jet. In aortic regurgitation, we're getting a jet of flow from the left ventricle, from the aorta into the left ventricle, and we use different equations here. So we again using an echocardiogram, you can use it by TOE, but you want to get a good view of the aorta and the left ventricle. And what we measure here is the width of the jet. So here we have the left ventricle outflow tract. And we're measuring that the proportion of the jet as opposed to the LVOT. So if you have anything more than 65% of the LVOT, that's deemed severe. Mild is less than 25%, and 25 to 64% is moderate. We can measure even finer, which is the vena contracta, and that's actually known as the the most narrowest point of the jet rather than the measurement of the LVOT. It's the narrowest jet width, and anything more than 0.6 is a severe aortic regurgitation. We can also measure the time it takes for the pressure to drop down. When you have aortic regurgitation, you get a drop off on the pressure from the systolic to diastolic. And the time it takes for that is known as the pressure half time. So the pressure half time less than 200 meters per second is deemed severe. Another sort of qualitative measurement is looking at the flow reversal in the aortic arch. So if we measure the flow reversal in the aortic arch and you get blood flowing backwards, that's also a marker of severe aortic regurgitation. These are the categories now, just like with aortic stenosis. Severe is measured by the jet width more than 65, the vena contracta 0.6, the regurgitant volume we can measure, and the regurgitant fraction, all markers of severity. This shows you a patient who we operated upon. He had aortic valve endocarditis. We can see the aortic valve here. It has some vegetation, some mass, which is attached to the leaflets. And we can see when we put the color, we can see a large proportion of flow going backwards into the LVO. This was severe aortic regurgitation. And so in terms of indications, the guidelines are very clear that with aortic regurgitation, that's an indication for surgery. If you're asymptomatic, then what we look at is other markers which relate to the size of the left ventricle. So over time, the left ventricle starts to adapt by enlarging. So the left ventricular end systolic diameter more than 50 millimeters, or if the ventricle starts to struggle, if the ventricular ejection fraction goes down below 50%. What we also find, many patients who have got aortic regurgitation may be amenable to surgery on the aortic root. If the aortic root enlarges, one of the ways we can treat that is just by replacing the aortic root, by doing aortic root replacement. There are new techniques where if the leaflets themselves are fine, we can spare the aortic root. There are procedures known as the David procedure or the Yaku procedure. And so valve sparing procedures are increasing in experience and frequency in the UK, and they have got very good outcomes. They avoid any prosthetic valve, a tissue valve or a mechanical valve. So if you can keep the patient's own valve, that's a very good solution. Another thing to consider is many patients who have got aortic regurgitation may have enlarged aortas. So if the aorta is more than 55 millimeters, we'll have to replace the aorta, ascending aorta and the root. If it's more than 45 millimeters, with patients who've got Marfan syndrome or other high risk factors, we'll intervene. In patients with bicuspid valve, it's often 30 millimeters. So it's interesting, every year, the results across the country are collated by the SCTS and the NICE, or the National Institute of Cardiovascular Outcomes. And this was the latest report that just came out a few months ago. And what they found was that across the UK, the number of TAVIs has been increasing overall, and the proportion of AVRs has decreased. And this shows you overall the format. So what we can see here, we can see the number of AVRs in blue, number of AVR cabbages in orange, and number of TAVIs. And actually, it was around about this sort of period, around about 2018-19, is when the number of TAVIs has been taking over the number of AVRs and CABGs. So the number of AVRs per se have dropped off, number of AVR CABGs as well. So this has had a significant impact on the work that we do. And 20 years ago, similar things were forecast when drug-eluting stents came along. Many people said that the cardiac surgery is a dying specialty, will be out of a job. And for sure, now, if you look at the number of patients who have stents to CABGs 4-to-1, there's plenty of work still for us, because many patients who have stents end up coming back for surgery. And similarly, there's already data showing that patients who are having TAVI, some of the patients, if they're, for instance, get endocarditis, or some patients who the valves don't last so long, they may end up having surgery at a later stage. So it doesn't mean the end for cardiac surgery, it just means that we have to be aware that the patient population is changing. And in many ways, what we all want is the best for the patient. We work in heart teams, we assess patients, and if some patients are too high for TAVI, other patients who are not suitable for TAVI, coronary height or bicuspid valve, other factors, then we'll assess them for surgery. And similarly in the US, this shows you the demographics in the US, where the number of TAVIs is actually, in a much far greater scale. So let's move on to the surgical management. This is what, for us, it's still one of the most enjoyable operations we do. It's one of the most satisfying operations, and majority of operations are still done by a classic median stenotomy, but there are many many operations now that can be done by hemistenotomy by different incisions. You can go through the third or the fourth intercostal space, and you can get a very good access of the aortic valve. And increasingly, the right anterior thoracotomy is being used, and that can be done to get good access to the aortic valve. Both these techniques, often minimally invasive through the right anterior thoracotomy, need to have peripheral cannulation often. So once we've opened the pericardium, one needs to assess the aortic valve. And the first steps are going on to bypass. So the keys are to cannulate safely. These are the first things that we learn: to put concentric purse strings, cannulate the aorta, free from a place where it's calcified, leaving enough space where we can put a cloth clamp. And then the venous drainage is often done using a two-stage venous cannula, so we can cannulate the right atrium into the IVC. And then once we've cannulated, then we need to think about stopping the heart. We need to think about also venting the heart. The heart itself, once you go on bypass, the heart will be emptied through the right atrium, through the SVC and IVC, but some blood will still get back into the heart. And when you're doing aortic valve surgery, what you want to have is you want to have a nice empty field, and sometimes blood comes back through the left ventricular apex and can fill the heart. So one of the vents that we use is a right superior pulmonary vein vent. Here we can make a purse string in the superior pulmonary vein. You pass this vent, which goes through the mitral valve, sits in the left ventricular apex, and helps give you a bloodless field. In order to stop the part, we use the classic cardioplegia. This can be done at the ascending aorta. If, however, you've got aortic valve, aortic regurgitation, another way of giving that is by retrograde. Here we can put a cannula through the right atrium into the coronary sinus and deliver that through the coronary sinus to get good cardioplegic arrest. Once you've opened the aortic valve, then the key is to identify the coronary artery. You can give further cardioplegia. There are different ways of approaching the aortic valve. Sometimes you can do a transverse aortotomy higher up. Other times you can do an oblique aortotomy. What you need to be very mindful of where the right coronary artery is coming off, because it's often you don't want to go too low, so you encroach that, and that might also impact on when you're putting in the valve prosthesis. The first steps of aortic valve replacement are basically to excise the valve leaflets, decalcify, debride the calcium along the annulus, so you've got nice tissues to able to stitch, and then getting very good exposure. So this would show you a nice annulus ready to be have valve implantation. There are different ways of putting valves in. This shows you one particular technique. You can use an everting technique, so you can have pledgets on the left and on the aortic side. That's called an everting mattress technique. That can be done if you want to have a valve sitting above the annulus. And then this technique is the inverting technique, or where you put the pledgets on the underside, and that allows a valve to sit just on the annulus. This sits above the annulus, and this shows you the different combinations here. Another technique is a semi-continuous technique, where rather than having multiple sutures pledged on, you can do a semi-continuous, many sutures for different quadrants. So you're using 4 or 5 sutures along different lengths of the aortic down nicely. What you want to do is sure the coriostia are clear. You want to make sure the leaflets open nicely, and then you close the aorta using either a 1 or 2 layer closure. And of all the sutures that you do, this is one of the most crucial suture lines that you do, because that has to withstand aortic pressure. And so the choice of valve prosthesis is something that's actually been open for a lot of discussion over many years. The early prosthesis, the very first heart valve, was invented by Albert Starr and Edwards. Edwards was actually an engineer. He had worked on different pumps during World War II. When World War II finished, he thought, why not invent an artificial heart pump? And at that point, Albert Starr, who was a surgeon in Oregon, he said, well, we don't even have artificial heart valves. Why don't we start with a valve, and then we work our way up to a heart? So they developed this ball and cage valve. So we had a ball and this cage with some cloth on the outside. This was called the Starr-Edwards valve. Subsequent to that, the mechanical valves were developed with these bi-leaflet valves. They're very similar now between the different companies. They're bi-leaflet, made from pyritic carbon, and they're mounted upon this this fabric. The other type of valves are biological valves. The early biological valves were from porcine. Many of the ones that we use now are bovine pericardium. So the bovine pericardium is cut into the right sizes, and it's mounted upon this stent. So these are stented biological valves. The guidelines are very open now. It's more, whether who should have a tissue valve, who should have mechanical valve. And for instance, the guidelines say mechanical prosthesis are recommended according to the desire of the informed patient. So it's down to patient choice. Age doesn't really come into it, but what they do say is patients less than 60 should be considered for a mechanical valve in the aortic position, and in the mitral position, less than 65. For tissue valves, there's, again, it's down to patient choice. So we have to, when we speak to patients, we tell them about what each valve has, the pros and the cons. With mechanical valves, needs lifelong anticoagulation with warfarin, regular blood tests, the risks of bleeding as they get older. With tissue valves, we have to inform them the risks of longevity and maybe further intervention, whether redo surgery or valve-in-valve TAVI. So in this guideline, it says anyone more than 65 should have a tissue valve in an aortic position. So one of the things I mentioned is prosthetic valve stenosis. So this is an concept that's been around for a long time. Patient prosthesis mismatch. It was first described in 1978. Is where when you put a valve in, the valve is too small for the patient's needs. And so this is a nice paper by my senior registrar, Raja Bilku. He published this very good review. I recommend to trainees, especially those sitting the exam. It's a very good overview. It's how to manage this particular problem. Over the years, there's been many developments in TAVI. Some of the TAVI technology has now moved on to the conventional aortic valve field. Now, what we have now is almost like a hybrid between conventional valves and transcatheter valves. So now we've got these rapid deployment valves, which can be put in very quickly. They reduce the time on the heart-lung machine, and they are actually very expensive. And this is one of the particular ones, the Inturity valve. This allows you to put the valve in. It's normally crimped, it's narrowed down, and then when you implant it, you can balloon it out, and then it can sit in position without any sutures at all. Newer valves are coming on, which are actually based on the same premise, the biological pericardium, but there are new ways of treating that by using different chemicals. For instance, the Inspiris valve is being used. There's new chemicals that are treating, and they're saying these valves may last up to 20 to 25 years. So they're being used in maybe younger patients. An even more exciting development is polymer technology. These are purely synthetic valves, and they've been done. The first in man has not been done, but using new polymers, which are meant to be very durable, less thrombogenic. So in conclusion, it's a very exciting time for structural heart diseases. There's many evolving technologies. What I would say for first of all, taking histories, examining them, attending the Echo Lab MDTs to get an idea of how to, these patients are assessed, and simulation. There's so many new tools now. When I sent to the ASSET course in March, there's a nice Ethicon. I've got a nice aortic valve simulator that you can practice putting in valves. It's reusable. There's a prosthetic valve made of rubber you can use to stitch, and it's very realistic in terms of anatomy. Thank you very much.